I'm here with Dr. Erin Shriver of the University of Iowa. Her specialty is in oculoplastics. Erin, you've done some amazing, groundbreaking work on the issue of domestic violence and the role of the ophthalmologist in the diagnosis and the opportunity to intervene and seek care. And I wanted to ask you, how did you get involved in this?
Yeah, thank you, Susan. It's a pleasure to be here. It actually started with a patient. I had a patient who had been assaulted by her boyfriend, and she had young children at home. And seeing her go through, she had a severe orbital fracture. We had to do the repair, and just seeing what she went through emotionally and physically struck me that she was actually had such inner strength. And I felt that I wasn't prepared to really talk to her. I didn't really understand what it was like, one, to be a victim of intimate partner violence, and two, I didn't feel like I understood the psychological implications of it, but I also didn't understand the ophthalmic implications of it. And so I decided to look into it more. And I realized that it really is prevalent that ophthalmologists, we're going to take care of a lot of these patients, and we don't receive adequate training in it.
So I wonder, could you share with us some of the key points that we as ophthalmologists can implement into our practice when we see a patient that has had trauma? Mm-hmm. How do we differentiate this, and how do we identify whether it is intimate partner violence?
Right. So I think the biggest thing we need to know first off is how prevalent it is, so we know to have it on our radar. A third of the women in the United States have sustained intimate partner violence. There's 12 million women a year, and 45% of intimate partner violence injuries occur around the eye. So it really is something that we are going to be the ones that are seeing them. So we need to know that first off. The second thing is we need to realize that if we don't, and it's not just women, by the way, it's men too, but that if there is trauma, we need to decipher or determine the mechanisms of an injury. So I think that's the biggest thing, is we can't rest on just saying there was an assault. We need to know who was the perpetrator of the assault, and take that as our responsibility.
And when you're approaching this, I know you have some excellent suggestions of how to make your patient feel comfortable and protected when you bring up the issue of domestic violence.
I think my initial lack of comfort with that first patient made me realize I got to get a handle on this. I'm going to be seeing these patients. I need to really make myself comfortable. And I realized by preparing and doing some research that I really was able to come up with a few things that I could say that actually research has shown is beneficial. And we've actually put it in a pocket guide, which has been published in Ophthalmic, Plastic, and Reconstructive Surgery. And we're going to be working with the Academy to create CME for it. But the first thing is to make sure that the patient is alone in a room. And the first time I did it, I was a little uncomfortable trying to figure out how to get her out of the room from her spouse, or sometimes it's the mother-in-law. But I found, I said, now I have a phrase that it's easy to say. I have to do part of the exam in another room. I'll take you next door, and we'll come back in just a little bit. And so once you have a woman alone, hopefully they'll feel more comfortable. And it's important to ask them, one, to introduce the topic, to say intimate partner violence is very common. It's something we see a lot, so I need to ask you about that. And then the question, usually how we've been taught to say it, I've worked with social workers on figuring this out, is do you feel sexually, emotionally, or physically abused, or have you been abused? And do you feel safe at home? And are there any children in the home? So that's all we have to ask. And then you kind of sum that up. Sorry, I know it's uncomfortable to ask this, or it's uncomfortable at times to talk about it, but it's something we'd rather risk that than risk your health or your safety. And we found actually that the studies show that women actually are not that uncomfortable talking about it. It's more our perception that they'd be uncomfortable, but they really appreciate you reaching out to them.
When we were talking about this, you pointed out something to me that was really startling, that most patients or most victims of domestic violence have been seen before. Can you share that with us as far as how we could intervene and help
Yeah. So 40% of murdered women are murdered by an intimate partner violence, and the studies show that over half of those women were seen in an emergency room within 2 years prior to that. There's actually been an oculoplastic surgeon who repaired an orbital fracture and talked to a woman about coming forward and seeking help, and she chose not to, and he saw her picture on the front of a newspaper because she was murdered by her husband. So it's something that if we can identify these women, get them help early, we can really save their lives.
So let me ask you, so you have a patient that you've identified that this trauma is by an intimate partner. What do I do?
The nice part about it is, one, you tell the patient that this is common, they're not alone. Actually, now I give them my paper to tell them this, I see a lot of these patients, unfortunately, now. So you make sure the patient feels comfortable, and then you ask them if they'd like help. And I think it's important that all of us just have one phone number. I have the social worker in my hospital. I can call them. I can say, hey, they're going to come on down and meet with you if you'd like. And that's all you have to do. Just get them hooked up. There's a domestic violence hotline you can call. You can ask who the best resource is in your area if you don't have a social worker or somebody that's already set up to be that person for you. But I realized it was this nebulous, uncomfortable, awkward thing until I came up with my system. And now I have a system, and it really doesn't take me very long at all. I go to the next patient, and the patient waits in the room and waits for the social worker to come. So I think that was something that I found was really empowering for me, and me being comfortable actually really helps the women. I'm not in a state with mandatory reporting, but I think it's important that all of us know that there are several states where there is mandatory reporting, and you need to disclose that before you would tell a patient.
Okay. And for all of us, we are really going to benefit from your research because I hear you're partnering with the Academy of Ophthalmology to put together a CME course on this, and that there will be resources for us online on the Academy's website.
Absolutely, absolutely. So right now, my orbital fracture data, where we showed that intimate partner violence is the third leading cause of orbital fractures in women, that paper has come out in OPRS, and we have a pocket guide for ophthalmologists. But we'd like to make that available to the broader group of ophthalmologists. And so the Academy is interested, and I actually have a meeting next week to go over. I've sent them all my papers, and the poster from here where we talked about ocular trauma, we found that every victim of ocular trauma actually had a ruptured globe. So these are severe injuries that are happening. And so we're going to be putting this together to help ophthalmologists around the country. I'm also working on a residency training program, because I think every resident in the country needs to learn this too, so that we can help these patients, one, get safe, their children get safe, and prevent more serious injuries.
Thank you so much for your work, and thanks for taking time to share it with us.
Thank you.